Hi, future clinicians. I am Lourdes, the founder of the NCMHCE Bible Prep. Today, I'm going to walk you through my clinical method, a framework I created, and I use myself to help you break down narratives like a real world therapist. And it's going to help you think clearly on the NCMHCE. I know firsthand how overwhelming these cases can feel at first, but this method simplifies what you're really being tested on, which is your clinical judgment. And it also tests you on your ability to organize information and your decision making under pressure. So, in this video, I'm going to walk you through step by step through a narrative I created myself. We'll discuss in key details, and I'll show you with highlights and we'll tackle a few practice questions along the way. And let's dive in. And remember, we don't just pass, we pass with purpose. Okay, so this framework is a structured approach that I created, which helps aspiring clinician. It helps you to organize your thinking while working through case narratives, especially when preparing for your board exam. Now, you're going to learn how to think like a clinician, spot important clinical cues, and you're going to connect client data to treatment decisions. And it's just going to help you improve your case conceptualization and critical thinking skills. So, the C is the presenting problem, basically, is the complaint, what brings the client to therapy. L is the level of functioning. It evaluates how the client is managing their daily life emotionally, socially, and occupationally. I is for impact. It explores how the problem is affecting the client across key life domains like their relationships, their safety, their work, etc., etc. N is needs. It identifies what the client needs for safety, stability, and support in the immediate term. I is interventions. Is the strategies that the client have been using or should be introduced to based on their specific needs. Remember, there's no one size approach to every client. Every treatment plan, every intervention needs to be tailored to the client's individual needs. C is coping skills. It assesses both healthy and unhealthy strategy the client uses to handle stress. A is assessment, summarizing the diagnostic impression based on what you've read in the narrative, usually within the mental status exam, and also the risk factors or anything that informs the whole clinical picture of your client. L is life goal. This is where your core counseling skills, your core attributes come into play. That highlights the client's values, your hopes, and their long term goals that should guide your treatment planning for the client. Now that you understand the clinical method, let's walk through a narrative I created so you can see exactly how to apply it step by step. Grab your highlighter, pause when you need to, or follow along as we break it down together. This is not just about theory, this is how we pass with purpose. As you can see, this client is Jasmine. She's 26, she's female. Her gender identity is female. She's heterosexual, biracial. Her relationship status is single. Her counseling setting is outpatient counseling center. She's in individual therapy, and her provisional diagnosis is borderline personality disorder. When you read the demographic information, don't just do what I did, skimmed it really quickly. I only did that because of the constraints of the time video. Like, I know we have things to do, and I know our attention spans can be short because of, I guess, the clock app. But yes, read the demographics with the intentions of, okay, her provisional diagnosis. What do I know about borderline personality disorder? That's the first thing I always do. I read their demographics and I say, okay, what do I know about this? And I start thinking. This is the aspect where you need to go to that compartmentalization in your brain from grad school to say, oh, we discussed this in class and this is what I learned. Or this is what the DSM-5 have to say. Oh, it's individual therapy. How I do individual therapy will be different on how I do group therapy. Oh, she's heterosexual. So, I have to think about, okay, if she was the opposite, maybe some cultural formulation interview or anything to kind of help gauge that. Oh, she's female. So you have to start thinking like that as a therapist. Okay, so this is her narrative. You can pause it if you want to, but I'm going to read it so that if you're multitasking, you can hear about the narrative and you can kind of see the flow. Just a quick heads up before we jump in, the highlights you see on the narrative were done ahead of time. I'll be walking you through each one step by step using a clinical method, but I had to pre highlight to make things easier to follow since as I'm recording, I'm not unable to mark the document in real time. So feel free to pause, take notes, follow along as if I were doing it live together because what we're doing is similar, but it's just with a little more extra. Okay, so we have Jasmine, who presents for individual counseling due to difficulties maintaining relationship and intense emotional distress. She reports that when she feels disappointed by others, that she experiences overwhelming anger followed by deep guilt and self-isolation. Jasmine shares that she sometimes feels like her emotions are too much and can change rapidly throughout the day. She described having lost contact with close friends after conflicts and says she often feels abandoned. She also reports missing several days of work recently because she felt emotionally exhausted and couldn't face anyone. Her mental status exam, she arrived dressed casually, but she looks disheveled. She's oriented to person, place, and time. Her speech is pressured when she's discussing interpersonal issues, but is also coherent. Her mood is angry and anxious, with her affect congruent to her stated mood. Her thought process is logical, though occasionally circumstantial. She has no hallucinations or delusions. She denies suicidal ideation, but she say things such as, "Sometimes I wonder if disappearing would make life easier." No immediate plan or intent is stated. She discloses she often drinks a few glasses of wine in the evening to take the edge off after a stressful day. Though she denies she has a drinking problem, she is prescribed a mood stabilizer, but she mentions she sometimes forget and will double up if feeling upset. Her psychosocial and family history is she describes a history of witnessing frequent arguments and occasional physical violence between her parents during childhood. She reports difficulty trusting others and a tendency to sever relationships quickly if she feels betrayed. Her unemployment history is unstable with frequent job changes. She has limited current social supports but maintains occasional contact with the older sister, though the relationship is strained. 2 weeks after the intake, she returns for a scheduled session. She's more fatigued and frustrated. She reports that following a recent argument with a coworker, she consumed half a bottle of wine and took extra doses of her prescribed medication to calm herself down. She minimizes the event, stating, "I just need to calm down. Nothing bad happened." She shares she missed additional work days and feel increasingly isolated, but does not recognize the severity of her substance use. Although she denies active suicidal plans, she comments that she feels numb and sometimes wonders if her absence will matter to anyone. Her 5 to 6 week later session after intake, she has completed short-term residential stabilization program and returns to outpatient therapy. She appears more grounded, she's dressed appropriately and maintains better eye contact. She reports attending 2 DPT group therapy sessions and practice mindfulness techniques at home. She acknowledges that her coping patterns and emotions she forgive me, she acknowledges that her coping patterns around emotions and substances have been unhealthy. She expresses both hope and fear about maintaining change, stating, "I don't want to screw everything up, but I want to keep trying." I went ahead and I read all 3 sessions just for the sake of time. So, in this right here, let's go through the clinical method. It's pre highlighted. So, the red highlight represent the C. We always start with the client's presenting problem. What brought Jasmine to counseling? Here you can see that the reason for the client to come to individual counseling is because she has difficulty maintaining relationships and she has intense emotional distress. She experiences overwhelming anger followed by deep guilt and self isolates. She feels like her emotions are too much and can change rapidly throughout the day. Those red highlights are the client's own words. So when you think about the C, which is the complaint, it's usually the client's own words. Okay. So that right there shows a strong emotional reactivity and interpersonal instability. And it's very common in individuals with BPD. Now, her level of functioning is in orange, right? So let's see how well she's functioning in her daily life. She missed several days of work recently because she felt emotionally exhausted and couldn't face anyone. She lost contact with her close friends after conflicts. She also has a strained relationship with her sister. These indicate moderate to severe impairment in both social and occupational functioning. So now let's get to the impact aspect. The impact is what I highlighted in yellow. This shows how the problem is affecting multiple areas of her life. Okay. So, for example, she says she drinks a few glasses of wine in the evening to take the edge off. She sometimes forget to take her mood stabilizers, but will double up if feeling upset. She also mentioned her employment history is unstable with frequent job changes. We're seeing here what we're seeing here is emotional dysregulation leading to substance use and poor medication adherence. And green is our needs. Based on the client intake, we get a clinical picture of her immediate needs. She says, sometimes I wonder if disappearing would make life easier. She also have a history of witnessing frequent arguments and occasional physical violence between her parents during childhood. That right there lets us know that we as therapists have to give her psychoeducation around medication adherence and coping strategy. We also need to do a risk assessment for suicidal ideation. And we also have to give her trauma informed approach due to history of witnessing parental violence. So those key things right there of her needs shows that we need to support her and safety and give her a sense of emotional stability while also preparing her for deeper work. That right there, that is the clinic aspect of this. Now let's go to the next page where we break it down further. Ignore the questions. Remember, I'm just showing you how to read a narrative. Now, again, her needs, she feels numb and she wonders if her absence would matter to anyone. Back again to risk assessment for suicidal ideation. In blue, those are interventions. She what she have already done, which is later on in her sessions. She completed a short-term residential stability program. She reports attending two DBT group therapy sessions and practicing mindfulness techniques at home. That's good. Whether the narrative stated that or not, as therapists, you should be thinking, okay, how can this client benefit according to their specific diagnosis? And those interventions with mindfulness techniques, DBT therapy, group therapy, those are interventions that align well with BPD. Now, for her coping skills, which I highlighted in purple, let's examine her coping skill. She says she consumes half a bottle of wine and took an extra dose of her prescribed medication. Right there, that lets you know that she's experimenting with unhealthy tools to cope. And not only that, again, she repeated if she feels numb and she wonder if her absence will matter to anyone. So she's experimenting in session 2 with unhealthy tools by default. So her coping style is impulsive and risky. Now let's talk about assessment. What would you do from a diagnostic lens and from a clinical lens before you even read her last session? Because from a diagnostic lens, I would refer her to group therapy. I would also practice with her DBT therapy. I would also teach her mindfulness to help her cope. And I also want to emphasize that although a client have passive thoughts, such as wondering how life would be easier if they weren't there, and witnessing frequent arguments and physical violence between her parents, we have to understand risk remains a concern to her because of her passive suicidal ideation and her emotional volatility. So now you have to think like a clinician what it is that I need to do for this client ethically, how to give her a proper treatment plan that align with her goals. Now, the last thing I want to talk about is L, her life goals. This is post her first and second session. And we have highlighted, I don't want to screw everything up. It's scary, but I want to keep going. So this means that she is willing to continue working on her trust issues. This tells us she also has a hope and desire to change, and that gives us a foundation for client centered treatment planning. Now let's take a look at the question. And these are like questions you will see on the state board exam, on your board exam. Number one, which counselor action will best support building rapport with Jasmine during the intake session? Okay, so for this question, early on, we need to build rapport for her. A says emphasizing finding immediate solutions to her workplace. Could that be the answer? No. Why? Because her presenting problem was not her workplace issue. Her presenting problem was a need for her to have healthy relationships. Okay? B, reflect her feelings of abandonment and validate her emotional pain. That's the correct answer because in the earlier sessions, especially with clients who have borderline traits, validation is key. Reflecting her emotional pain helps build trust and shows empathy. The other options are too directive, they're rigid, they're premature at the intake stage. The intake stage is all about building rapport, baby. You don't build rapport, you already strain the relationship with your client. C, explain clinical boundaries in rigor detail, recommend immediate participation in group therapy. Again, it's all about building client rapport. Let's move on to number two. Number two, which client statement best support emotional dysregulation as a core feature of BPD? A, I stay away from people now to avoid drama. B, sometimes my feelings get so strong I don't know what I'm doing until later. C, I'm thinking about moving to a new city. D, I wish I could make more money. The correct answer will be B because this answer reflects impulsivity and intense emotional swings, which are hallmarks of BPD. It shows a loss of control in the moment, which is central to emotional dysregulation. The other options describe avoidance, future planning, or low mood, not dysregulation. Number three, what is the most appropriate first clinical step regarding Jasmine's passive suicidal ideation? A, ignore it until she explicitly mentions a plan. B, complete a thorough risk assessment during intake. C, assume it is simply related to her relationship difficulties. D, recommend immediate psychiatric hospitalization. If you pick B, that is the correct answer because any expression of suicidal ideation, even passive, requires immediate assessments to evaluate risk and ensure safety. This is a standard and ethical protocol. Ignoring or assuming is dangerous, and hospitalization is premature without risk evaluation. Sorry, I'm moving along too fast. I just want you to get the gist of the narrative and to use the clinical framework. If you really would like assistance, you can reach out to me. You can email me or book me for tutoring sessions, and I'll be more than happy to help you to pass this test with purpose. Let's do the last two. Number 6, 7, and 8. You can do it your own, or you can click the link in Gumroad and you can finish this with the answer rationals that I have. Number 4, from an ethical perspective, which principle is most important to uphold at this stage? A, client autonomy and collaborative goal setting. B, counselor's duty to diagnose swiftly. C, managing counter transference privately without supervision. D, guaranteeing client employment assistance. Let's talk about the incorrect. D, already, you can cross that out. Guaranteeing client employment assistance. No, she doesn't need that. It's what is the most important to uphold at this age. That's not it. Um, Management counter transferring privately without supervision. That is incorrect. There was no talk about the client or the therapist experiencing counter transferring in this narrative. B, counselor's duty to diagnose swiftly. That is incorrect. The correct answer is client autonomy and collaborative goal setting. Because from an ethical perspective, we have to respect autonomy. So that means in her treatment planning, we have to help her feel empowered. This supports the therapeutic alliance and aligns with the ACA Code of Ethics. Diagnosing too quickly, managing counter transferring without supervision, or focusing on unemployment aren't ethically central right now. What's ethically central is giving her autonomy and being collaborate with her in her goal setting. Last one we're going to go over is what clinical risk is most concerning after Jasmine disclosure. A, feelings of isolation. B, medication noncompliance. C, substance misuse combined with mood stability. D, employment difficulty. Okay, so the combination of her misusing substances combined with her mood instability, as a clinician using that clinical framework, you would have realized that that's the most that's the most concerning. Why is it the most concerning? Because it is our duty to help her, give her psychoeducation. Because if she's taking wine with her medication, she's skipping doses and she's taking more than one dose. And this is a client that also is experiencing fleeting ideas of suicide. That means that she's a harm to herself. So the correct answer is C, substance misuse combined with mood instability. Because is more urgent than just isolation or employment challenges. Mood instability and substance misuse together are red flags for BPD, especially when paired with suicidal ideation. So, we will stop right here. You can do 6, 7, and 8 on your own. If you would like more videos like that, please comment below, like, subscribe. I'm doing this to teach you what I had to teach myself in order for me to be successful. I have volume one, I'm going to post it. It's going to have more breakdowns for you. This is another case I did, which is Marcus. And if you can't wait for me to walk you through Marcus' case, or if you're feeling confident using the clinical method and want to challenge yourself, go ahead and download volume one. The link is below. The case is in there along with other powerful narratives that I created to help sharpen your skills. And remember, if you ever feel stuck or you doubt or you're doubt on yourself or you need assistance, feel free to reach out to me. I'm here to help. You can also reach out to me on my social. Linktree is at the bottom, or you can also email me if you have any questions. If this was really helpful to you, like, subscribe, send me a message, or leave a comment. I create these resources because this is the things that I needed when I was studying. And if you didn't know, if I didn't share already, I had to take this test 4 times before I passed. The first 3 times I've used what other people were using when I really sat down and I honed in and I created my own. I did the research. That's when I pass that exam. And I did well. So now I'm sharing with you what I use that can potentially help you. So if you would like a tutoring session or just a quick call, just let me know. Link is in the bio. Thank you.